Thank you, Amit, for having me as a part of this symposium on imaging. And I'm going to talk about elevation-based tomography with Pentacam AXL, how to use this in various indications in ophthalmology. I'm not covering the AXL wave. It's basically adds on a little bit more aberration, angle alpha, kappa, and centration of the lenses. Uh, so basically, as already been highlighted by the previous speaker, that there are various gadgets and instruments for doing corneal tomography, which are slit scan based rotating shine plugs as well as OCT based. And I'll be restricting my talk to Oculus Pentagram, which is based on rotating shine plug scanning slit tomography. And basically, it has been in use for screening for refractive surgery to rule out keratoconus or ectasia or progression of keratoconus. And of course, it has also been in use for doing cornea and refractive surgery in terms of phakic IOL and intrastromal corneal rings. Basically, any corneal based refractive surgery or rule out keratoconus or postoperative ectasia, all those things come in domain of, I mean, we can do a imaging with pentacam and have a good idea about the situation whether the keratoconus is stationary, progressing, or what. And in cataract, of course, one can do a lens-based densitometry, which has, as we all know, compares well with the LOX3 classification as far as density of the hardness of the cataract is concerned, and also especially in post-refractive surgery IOL calculation power, we have this true net power as well as Holaday equivalent K readings on pentagram, which can be used to arrive at a good IOL power in such cases. And also it has a use to choose the aspheric IOLs and also in toric IOLs, because it gives a wavefront based cylinder, which is axis is quite accurate. I won't be discussing the application in glaucoma. So screening for keratoconus or form fluus, already it has been highlighted by the previous speaker. So as we all know that on the anterior elevation map, a value of elevation of more than 12 micron is considered normal, and a value more than 15 micron in the central 5 millimeter of best fit toric ellipsoid mode are typically indicative of keratoconus, and similar number about 5 micron more apply to the posterior elevation map, and these values are significant only if present in central and paracentral area and in localized pattern. Higher plus values may be seen in periphery because of astigmatism, and they do not mean necessarily the abnormality. So this is one such front elevation and back elevation. As you can see, the front elevation is plus 27 micron and back elevation is plus 53 micron. So it's abnormal elevation in an island pattern on both the surfaces, and this is the other the anterior elevation of the same eye, which is much higher. And it could be also in the shape of tongue, which is called peninsula, coming tongue-like projection both on the anterior and posterior surfaces, or it could be a full bridge pattern also, which also has a quite great specificity. 95% of the patient of keratoconus may have a bridge pattern in their topographic map, and this is the other eye of the same patient showing great elevation of the anterior surface, and the corneal thickness is quite low, 493 micron. And this is one represented patient who presented for LASIK with this much of myopia. If we see, the thickness is quite okay, and there's a little bit of asymmetric bow tie. But if we see the posterior elevation map, there is significant elevation on the posterior map. So there is a topographic sign. Clinically, you may miss it. And this is the other eye, as already by other speakers. So other eye has a frank keratoconus. So it's a fellow eye of the fellow eye in a case of keratoconus in the other eye. So in case of doubt, we have to look for various parameters on Bellin-Ambrose's enhanced ectasia display and comprehensive pachymetric evaluation. What it means is, like in this case, there is a slight asymmetric bow tie with thin cornea and little peninsula. And what this program does is a 3.5 millimeter optic zone centered on the thinnest point is excluded from the reference shape of the calculation. So what does this do is it creates a new reference sphere which has a minimal effect on the normal cornea but greatly enhances the ectatic area of an irregular cornea. Like in this case, this is with the best fit sphere, but with the new reference shape, this ectasia is enhanced. So the probability of diagnosis increases. This is bad map of one such patient where there is both anterior and posterior elevation. This is nothing but a difference of this two maps on the this side, and red values are significant of they are significant, and the sensitivity of screening for keratoconus suspect or from first keratoconus increases with this software, and it is easier to screen cases for refractive surgery. And this is on this map you have to look for this values. Overall value here you can see is around 7.84. It is in red. It's beyond 2 standard deviation. Pachymetric progression index is around 2.1, as well as artmax is around 160. All these are significant, and once the value become more than 1.6 diopter of standard deviation, they are thrown in yellow. Once they go beyond 2.6, which may not almost 3 standard deviation include 97.5% of the normal population. So that increases the specificity of this program. So these are the various parameters we should be looking for on this map. This is these are 5 values. This is anterior elevation, the thickness variation, then the pachymetric progression, thinness pachymetric point, and displacement of thinness point, and artmax cutoff micron is 399. This is A is ratio of artmax this thing to the thinnest cornea, and this is a combined value of this. This combined value is much more important than the individual values. If this is in red, there is definitely no for the surgery. If it is in yellow, you can wait and watch. And this is another patient with frank keratoconus. You can see all the instances in red, and this is a frank case of keratoconus. And on holiday report, if you see this is normally we are doing a comparison to a best fit sphere, but here we do a elevation on a best fit toric ellipsoid, because cornea normal shape is best fit toric. It's a toric ellipsoid. So if a hotspot on tangential curvature and relative pachymetry which is less than 3% of the variation and posterior elevation more than 15, coincide, it is a definite diagnostic. So this has already been discussed. Form first keratoconus. This is another patient, 24 years old. Everything is normal, but except for the K rating, which are very high. Even the corneal thickness is normal. So you have to be careful in such cases. You have to ask for family history or disease of maybe in the sibling there is history of keratoconus, or you may go into for genetic testing of these patients where are various genes described in the keratoconus, because all of us know that age is the single most important risk factor for development of keratoconus. And this map shows pachymetric progression. Normal is around 1.2. Here it's a little, maximum is around 1.5. And here you can see the again the pachymetric progression is in yellow. It's more than 1.6 standard deviation, and the whole D value is also ambiguous. It's not absolutely normal. So you may observe these patients and follow up it after 6 months, and as we follow up And this is the other eye, which has a higher value than the right eye, and even the pachymetric progression is in the red zone. So all these cases are to be followed up closely without doing a refractive surgery. As far as IOL power calculation is concerned in post-refractive surgery eyes, these are the various online calculators available. But of course, with the Pentacam, it gives us a true net power as well as equivalent K readings, because it takes into account the true anterior and posterior curvature as well as the true refractive index of air, tear film, cornea, and the aqueous humor. And these are the various EKR values, which it has been shown that the values at 1 to 2 millimeter are more important than 3 to 4 millimeter. It has been proven by Savani et al. In their paper that the central 1 to 2 millimeter values are much more accurate as compared to the 3 to 4 millimeter diameter. So this is a representative patient, 39 years. This I operated almost 15 years ago. Patient, she had undergone a radial keratotomy. So he had 8 RK scar, axial length was this much, and on manual K, this was the keratometric reading, and on SRKT, this was the lens power coming. So, but on EKR, at 1 and 2 millimeter, the average K reading was around 35, which is less than this. And in this patient, once you calculate with AKR, you get a power of lens of 18.5, but with this one, you get a 17.5. So you will end up hyperopic by 1 diopter. So you target for little myopia. So we targeted 19. So post-op patient got this much of cylinder on day first. Spherical equivalent was still on the positive side. So as far as higher order aberration are concerned, you can choose based on asphericity, spherical aberration, the IOL, which specific aspheric lens you want to use. So based on how much is the asphericity, just last slide. If the patient has undergone hyperopic LASIK, you will like to choose a traditional non-aspheric IOL with positive spherical aberration. If a patient has undergone a myopic, patient has usually have a more positive spherical aberration, so you'll use a lens with the wavefront negative spherical aberration. In irregular cornea, you like to use a aspheric neutral lenses. And if there is no previous refractive surgery, again good centration and uncompromised capsular bag is there, you can use a aspheric IOL with negative asphericity. And if there is any subluxation or pseudo exfoliation, you may use a aspheric IOL with this thing, because this Pentacam gives a asphericity value of cornea at 6 millimeter. Based on that, you can choose. And this is one case where one eye has a non-aspheric, other has a aspheric. You can see the Stahel ratio in the two. It is way close to 1 in the left eye, and in right eye it is almost 1/10 of the left eye, and the point spread function is very good in the left. Quality of vision is very good. This is again on a Pentacam, not on a Pentacam, the earlier version of Nidec, this thing which shows very good point spread function. So based on this, we can have a lot of application of Pentacam. I have not gone to detail of other. It has a lot of other uses in glaucoma, ICL, as well as intracorneal intakes. So it's a very versatile tool and can help us in various situations in analyzing progression of keratoconus, calculation of IOL power, and all. Thank you so much.